Welcome to this comprehensive clinical review on myocardial infarction, covering its pathology, diagnosis, and treatment within the cardiovascular systems. Myocardial infarction, or MI, is defined by the death of cardiac tissue due to obstructed blood supply. Clinically, it presents as myocardial ischemia, characterized by prolonged, sudden-onset chest pain, often localized to the substernal region. Clinical indicators include biochemical markers in the blood, ECG changes, and evidence of myocardial injury on imaging. MI can be classified anatomically as transmural or non-transmural. Transmural MI involves ischemic necrosis across the full thickness of the muscle segment, from endocardium to epicardium. Non-transmural MI limits necrosis to the endocardium or myocardium, concentrated in the subendocardial zones, which are vulnerable to low flow. There are 5 clinical types of MI. Type 1 is a primary coronary event like plaque rupture. Type 2 is ischemia due to supply/demand mismatch. Type 3 results in sudden cardiac death before markers rise. Type 4 is associated with PCI or stent thrombosis. Type 5 is associated with coronary artery bypass surgery, or CABG. The primary cause of MI is often the rupture of an atherosclerotic plaque in a coronary artery, leading to spasm and thrombus formation. Other risk factors include coronary artery spasms, drug use like cocaine and amphetamines, hypoxia from conditions like CO poisoning, and coronary embolism. Pathogenesis involves myocardial necrosis, beginning within 20 to 30 minutes of coronary artery occlusion, typically starting in the subendocardial region. The subendocardium is the last area to receive blood, making it highly sensitive to increased internal pressure that further compromises flow. Typical manifestations of MI include sudden chest pain that may radiate to the left arm or neck. Other signs are shortness of breath, also known as dyspnea, excessive sweating, or diaphoresis, and symptoms like nausea and dizziness. Major complications of MI include arrhythmias, which are abnormal heart rhythms due to electrical circuit damage and a leading cause of early death. Heart failure occurs when damaged muscle is too weak to pump enough blood, causing fluid buildup. Heart rupture is a life-threatening event where the heart wall muscle breaks. Observing the timeline of cellular death, necrosis reaches its maximum extent after approximately 24 hours of total occlusion. Diagnostic protocols include the electrocardiogram, which detects electrical abnormalities and location of ischemia. Cardiac markers like troponin and CKMB indicate heart muscle damage. A chest X-ray visualizes heart size and fluid presence. Finally, a stress test evaluates heart performance under controlled exercise. Emergency management includes coronary angioplasty, where a balloon catheter clears the blocked artery, and stenting, which leaves a small scaffold to keep the artery open. The goal of these procedures is reperfusion to salvage heart muscle tissue. Pharmacological treatments include thrombolytics like streptokinase to dissolve active clots. Blood thinners, such as aspirin and clopidogrel, prevent new clots. ACE inhibitors lower blood pressure and reduce cardiac stress. These are the image sources used in the video.